I'm Dr. Mahesh Desai. I'm a senior urologist in this hospital. This hospital is Urology Patel Urology Hospital. It is basically for renal diseases. It was established in 1978, and from the first day I'm involved in this hospital. It was started by Dr. Mahesh Desai, who was my senior colleague in England. We were trained in England in urology because at that time urology was not a specialty in India, including nephrology. Nephrology is a medical part of it. And at that time there was no facility for dialysis or transplant. So Virendra Desai thought of building this hospital, very small at that time, and in 1978, and we had a 2 dialysis machine. First time in Gujarat or Western India, and then we started doing. But that time we had majority of the patients were with the stone. And we started the stone. And as just happened in 1980s, there was a technological explosion, and lithotripsy, USWL, CNL, you puncture the kidney and then take it out, or ureteroscopy, it become, or some open surgery. They came into practice, and then we adapted that in 1984-85, first time in Western in Gujarat, and but we thought that PCNL was the most cost-effective treatment because we had a very large stone. So we punctured the kidney and then with the telescope, and then with ultrasound we broke the stone, took it out with only small puncture. And then of course we started analyzing and then putting into the stone. And at that same time, the new technology awareness started coming, and then we bought ultrasound so as to facilitate the puncture of the kidney. But that ultrasound can be used for diagnosis of various diseases of kidney, ureter, bladder, and the prostate. And at that time, the prostate cancer become supposed to be the number 1 cancer in urological cancer, and then mortality because of the prostate cancer was 3 in the third, and that time stemming from California, Stanford, he invented PSA, prostate specific antigen, which would predict whether the patient has got a cancer or not. And then it was so good, it was published in 1987, and we could acquire it in 1988. So with PSA and with ultrasound, we got interested in prostate cancer. It just happened that when we got independence, our population age was between 45 to 50, and now the population age was increasing, and it was going up to 75 to 80, and the prostate cancer becomes more active. But there was no awareness. The patient came with the metastasis in the bone, and the patient would have a simple orchidectomy and the stilbestrol. That was the only treatment. But we thought of doing some investigation, and then we did a population survey to find out what is the level of PSA above which we can detect or suspect having a prostate cancer. And we did nearly 39 villages, and we found that our prostate was small, and if PSA was more than 2.5, then we will have a prostate cancer. So then we started doing ultrasound and investigation. We started detecting earlier. and then we started doing the surgery. But that time there was only open surgery, which was a bit difficult, and then patient had an incontinence afterwards, and there was little risky. And then, but at the same time around at the end of the century, we started learning laparoscopy, and then we could use a laparoscopy instead of open surgery. And with early diagnosis, we started doing the laparoscopy. We did had a high intensity focus ultrasound where we used to destroy the prostate cell, especially if patient is aged and he's got an early cancer. We were using it. I believe now the new technology is there. And what is most important was the diagnosis. To do an early diagnosis. So we found that the prostate cancer was, the incidence was increasing, and people used to come to us little late with cancer gone out of the prostate or sprayed to the bone or a lymph node. And because our aging started and then in last 20-30 years, people will become more older before they die. So this prostate cancer becomes increasing, and we started diagnosing it, as I told you, with doing the PSA and digital electric examination. And if the gland is hard and the PS is more, we used to do a transrectal sonography, try to locate the prostate and then do the biopsy. But before doing biopsy, we used to do MRI. And over the period, the technology improved, and then there came the new ultrasound machine, which is known as a micro-ultrasound, which is ExactVu, and which has been marketed by the Wellnect company. And then when they introduced it, is known as a micro-ultrasound. And then when I saw the probe was 29 megahertz, and it was 300 times more resolution. And then previously I could ultrasound would give me the shape, symmetrical gland. Then there is a echogenicity, whether there is a hypoechoic or a hyperechoic. Hypoechoic was more associated with the cancer. And then but we used to do MRI to see if there is a cancer, and then the localization is done on ultrasound, and we used to take biopsy. Now, as soon as the patient comes and with the symptoms, we do the PSA, we do the digital electric examination. If it is hard and the PSA is more, we do the micro-ultrasound, and this an ultrasound gives us a suspicious area. Now, as I showed you earlier, the ultrasound gives you the different grading. The Primus 1, Primus 2, which is a benign. Primus 3 is sometimes with the inflammation or stone, or sometimes small cancer can alter. But 4 and 5 is more associated with the cancer. And they had a particular echogenicity and architect, and which we could identify because it was magnification was much higher. And then we used to take immediate biopsy, and then we found that presence of a cancer. Now, previously we used to take a biopsy probably about 12 to 18 from the whole gland, and then we used to try to find out, because we could not identify the particular location. There may be cancer in the prostate, we will take more. But now, with the micro-ultrasound, we don't need an MRI. We can see the abnormality, we can look at the signs, and we can take a precision biopsy or a targeted biopsy, which may be 4 or 5. And that is enough to diagnose the the case, then enough to give you the grading of the prostate cancer, and then we can decide the further line of treatment. And I think there is a tremendous change. And then after that, we decided that now not to wait for the prostate cancer, and but to go ahead and then do the screening of the population. So we started the screening in Kheda district. There is an organization, a senior citizen club, and there are 4,000 male members above age of 50. So we take one village and about 60 to 70 male members, and we take the history. A family history is very important, because if there is a cancer in the family, father or brother or uncle, the chances of you getting the cancer is about 35 to 40%. So that is a very important. Then we do a digital examination and the PSA, and then if we find anything abnormal, then we do a transrectal. We do the transrectal sonography anyway in every patient, and in this patient we will try to look for an abnormality, and then if we find any primus variation, we will do the biopsy. We have done so far about 800 to 900 cases. We have screened them. We have found abnormality in 40 to 50 cases, but we found the cancer in 18 cases where we have done a robotic radical prostatectomy. Clear. Now all of them are organ confined, so we could do the early cancer. Now we have been able to educate the patients. At age turning age 45, you should do a PSA and let one if there is a family history, get the urologist to examine your prostate. If PSA is more than 2.5, because internationally the cutoff value is 4, but we are different, and we are mostly vegetarian. And then we have done the survey of nearly 39 villages where we found our prostate is small and our PSA cutoff value is 2.5. So about 2.5, we start screening more looking for the prostate cancer. Our prostate is small, so chances of prostate getting out is more quickly. So we have to do the early diagnosis and then the treatment. So I think from my experience of last more than 1 year, I feel that this new ExactVu or Micro-Ultrasound has really changed our approach to the cancer of the prostate. And I'm thankful to the Wellnect who has been helping us with this technology, and we are trying to do a little bit more research, because we are different than the Western people, and this is the only machine so far. So we are trying to look at our prostate cancer, how it is appears, what are the grades, what are the spread and everything. And hopefully we will be able to help the patient with the prostate cancer. The most important, remember that age, about the age of 45. Second thing, if the patient is obese, is a smoker, is a diabetic, and got a family history, then chances of prostate cancer increases. They should get checked out. That is most important. But not only once, but if at the age of 45, the prostate PSA is normal, but it may slowly increase. So every 5 years, 3 years, 5 years, you should go on checking your PSA and making sure it remains. But if it remains for say 10 years, then chances that it will not increase. But if it is increasing, then you should get checked up regularly. Most risky time is between the 55 to 65 or 70 years.